Now, we'll go to the panel discussion, who will be moderated by Dr. Kirrily de Polnay, a former MSF nutrition advisor who is currently working at WHO in the Nutrition and Food Safety Department. Over to you, Kirrily.
Hello, everybody, and thank you so much for inviting me on to moderate this panel. As Sophie said, huge goosebumps, just so important, all the discussions we've been having. I'm just so happy that we're discussing this in MSF and that we're really sort of pushing boundaries. So we'll be having all our fantastic speakers back to the panel, and also two new panelists will be joining us. We have Livia, who is joining us from Brussels, at one of the headquarters in Brussels, Livia Tampellini. She has been with MSF since 2006 in the field as a doctor, as medical team leaders, as medical coordinator. And since 2019, she's been in HQ and working in the operations covering East African and Haiti. We also will be joined by Honorine, who is a registered nurse, trained in Rwanda, has worked with MSF also for many years, and has been very much pivotal, involved in KMC as her role as a nurse and also as a medical team leader. So welcome to you all. Thank you so much for being here. Now, I'm going to start off with some questions and to our new panelists, just to give our speakers a little rest. But I'm going to start with you, Honorine. Now, you have been working in many countries with MSF in many different projects. So from your viewpoint, how do you see, where do you see we are, in fact, for family-centered care in MSF? Where are we?
So thank you very much. As you said, I'm Honorine. I'm currently medical team leader with MSF. I've been working with MSF for 5 years. I started in Haiti as a pediatric nurse. So I was working in a KMC ward. And I went to Central African Republic as KMC implementer. So where we are now as MSF, so I would like to thank MSF because they gave me opportunity to implement KMC in the Central African Republic. It was quite new. So when I started in the two projects, Bosangwa and Ibambari, it was new when I was talking about kangaroo mother care. Some of staff, they were even calling me Mama Kangaroo because yeah, it was a new topic. So when we started, before they were mixing babies and other children. And then we started like separating babies. And after we negotiated with a medical director, because it's MOH hospitals, and then they gave us the room. Yeah, but the idea came from MSF. And now where we are now, we have rooms for KMC, at least with 10 beds. And then now we are also in the health centers and the community level, where we are training mothers. So during antenatal care consultations, because where we are in the car, we are referring mothers, they are coming on maternity, yeah, so they have to put babies on KMC when they are being referred. So now kangaroo is being plugged in the community at health centers levels and in the hospital, yeah. That is where we are. So, so now kangaroo mother care is no longer the topic for medical staff only. And now health promotion team, they are trained. So we are also working with mental health team because, when the mother is practicing kangaroo mother care, it takes time. And some of them, they even get like depressed. So we have mental health team, which is like coming every day, passing in a kangaroo mother care ward, so to talk to mothers. Another team is IPC team, yeah, where we are like working with mothers. We are doing like sensitization about hygiene, yeah, personal hygiene. And another thing also, we are like involving other family members when the mom is seriously sick, so the father can practicing kangaroo mother care or another family member. Yeah. So it's no longer kangaroo mother care. Now sometimes we call it kangaroo further care.
Perfect.
That is where we are in as like low income country. Yeah.
Thank you so much, Honorine. And I really love that you're bringing in the importance of the health promoters and the mental health staff, our IPC. We know that we need everybody involved in KMC for any pediatrics or any nutrition project.
Yeah.
So that's such an important element, I think. Next, Livia, coming to you. How do you see kangaroo mother care fits with our values as MSF as a whole? How do you see that?
Thank you. Well, of course, for me, this zero separation that it's definitely is fitting with our value. It's when we, as MSF, we want to be a medical organization and we want to see the patient 360 degree and understand where it's coming from. But of course, imply that the patient is not only a little baby, but his baby is coming from a family. And this is inside of, it's for this that I like this strategy, this idea of zero separation. I think is we need to be as MSF a pioneer on this, because it's we believe to be a medical organization who is challenging and find a new solution. There are the zero separation and the immediately kangaroo, I think is nice also because it's affordable. It's not only for our following our value, but it's affordable everywhere. And everywhere we can ask the mother to stay with the baby far more than any kind of fancy biomed solution that we can find. That of course were a good solution, but a mother or a father or a family member is a far more affordable in the context where we are working. So it's for me it's also important because it will fit in the fact that will shorten the bridge between the medicine that we are doing in poor country and the same medicine that we are doing in other country. And then also wherever we will be, we can propose. I'm not afraid to propose in the middle of nowhere in the same way than in a place where I can find doctor and nurse without issue. So yes, definitely, I think there are so many points that are fitting in our strength, in our capacity.
Thank you, Livia. Thank you. I think that's really, when you were saying about it made me think about the sort of real founding sort of principles of MSF and proximity, and this just reinforces all of that. And that equity aspect, I think we all feel that so strongly, trying to move closer to what we can provide for infants in high income settings and low income settings. And I think that's so important. So next, Bárbara, I want to come to you. You did talk about this a lot in your presentation, but sort of tell us again, sort of we've seen that this family-centered approach, it's going to be a bit of a mindset change for quite a few healthcare providers, and a little bit of away from maybe the doctor knows best and the doctor knows what's sort of best for the child, the family. So in your experience, what have been those sort of points of resistance that you felt from some health providers, and how is the best way to overcome these?
Thank you for your question. The truth is that it's very difficult to change how you work with your patient when you have been doing your job for many years. In my unit example, several nurses were reluctant to let her perform some of the typical tasks, and they felt coming by them. So
Bárbara, we're losing you quite a lot. You're cutting out quite a bit. I'm just wondering, maybe we love seeing your face. Maybe turn off your camera just for a second so that we can hear you, unless we've lost you completely. Bárbara, it's breaking out a bit, but we can come back to you, Bárbara, or just try one more time for us.
Okay.
Oh, we can hear you.
Yeah?
Yes, go again.
Sorry. I think that it's very difficult to change your person.
Bárbara, I'm so sorry. We're cutting out. We're cutting out. Save that thought. We want to hear it. I'm going to come back to you, okay? And we'll see if there's anything we can do from our end, but please save that thought. Next, I just then want to come to Naomi. You know, you were involved in this trial. You saw a lot of the healthcare providers being involved, and maybe you had to sort of train some people for the study and for the work. Tell me, what kind of competencies do you think we need from healthcare providers to be able to practice this family-centered care?
So the competencies that we might need, first of all, we need to train our healthcare providers, including the nurses and the doctors and everyone at large, whoever is going to be involved in taking care of these patients. All of them need to be trained, and involvement of the mothers and whoever is going to assist, whether it's the father or their relative who is going to be there, also need to be trained and need to be educated on the importance of family-centered care. And yes, it was a challenge initially, because it's a new thing. You have to educate people, you have to tell people the importance of immediate kangaroo mother care, the importance of involving the mother right from the beginning, the importance of zero separation. But later on, it gained access and people understood and nurses understood. And then it became easy for everyone to partake and help the mothers, and the mothers were free to talk to the nurses, they were free to ask, they were free to do to help the babies, and even the surrogates, whoever came to assist. Initially it was a problem, but later on when we explained to them what we were doing, it became easy for them to accept easily.
Thank you, Naomi, thank you. Tasmin, I want to come to you now, and again, just echoing Sophie, it's so great to have a parent representative here. We're so appreciative, and so many things you said, and also listening to that mother, the video was talking about, I want to know every step of the progress with my babies, and I think that's so important. And what you were saying as well about being sort of too scared to pick up your babies when they're so little. I mean, I've had the same experience with mine, and that fear is very real. You've mentioned this a lot in your talk, but tell us again, because we can never hear this enough. What are those really important elements in that relationship between healthcare providers and parents that need to be there to make family-centered care, to make zero separation happen?
So I think, once it is established that the parents are at the center of the baby's care, that they are not just visitors, it automatically just opens up the gates of communication. And that's what I found in our experience. Like they saw that we were interested, they saw that we wanted to learn, and so it just made it more easier for them to integrate us into the care of our babies. And we were part of the team. I mean, I remember there was a situation whereby, as it happens in our country, there was a huge strike, and I was like, okay, if there's no nurses coming into work today, I've got this, I can help them, I can jump in where need be. Because of the education that I was given, because they spoke to me as part of the team. When I didn't understand anything, they would explain it in layman's terms so that I could understand. So we just need to get over that barrier of doctors on one side, parents on one side. Once we realize we are a team, because we all want our babies to survive, we all want the babies to go home thriving. That's the common goal. So as long as we understand that we are not in competition of each other, or that one is more important than the other, I think the way forward looks very promising.
Thank you. That's great. So it's really, you're saying there's that sort of the trust element, really seeing and an equal, really being seen as an equal, being seen as a team. So that seems very, very important. And also, as you were saying, that really important element of explaining things in layman's term, not sort of hearing lots of medical terms and parents not maybe having the confidence to say, I don't know what that means. So that's a really important point. And then leading on that, Bárbara, I don't know if you're able to give us a little sound test.
Yes.
Can we hear you?
Here.
Let's try again. Look at Barbara, she's right in the thick of it. She's got her scrubs on, she's in hospital. So just coming back to you again, I've got two questions for you now. You went away and now we've got two questions. So my question for you was about the points of resistance, and that you were sort of saying, we know it's hard changing our ways, but talk to us a bit about that.
Yeah, I was saying that the truth is very difficult to change your job because you have been doing the same job for many years. And for example, in my unit, the main issue was that several nurses were reluctant to let parents perform some of the typical nursing tasks, and they felt examined by them. And some of them didn't understand their role with the family, with that families and with the family integrated care model. For this, it was essential to carry out an initial training and also an annual training to refresh the importance of the parental participation in the care of their children and how we can guide their families and their training as facilitators. Because it's important to explain that we are facilitators for the families and that our work continues to be very important, but the role is changing.
Thank you so much. But I'm going to keep you because we've got you again for another question, which I think is really, I think you'll be able to talk to us about, and especially seeing how you were talking about having mentors. So, we've talked about the training, but how? What's the best way? We know sometimes, didactic training and your PowerPoints, but how do your mentors help? How do we have that sort of bedside approach? How would we bring that?
It depends on the unit or the group of people, but in general, I think it's a good option. The first part of the training, a theoretical part like e-learning or similar, and after prepare different face-to-face sessions to discuss the doubts or the different questions about that training, because it's important, the communication between the different people, and is the essence of the family integrated care. For example, in my unit, we are doing every year a refreshing about the training. Now with the Rising Family project, we did e-learning, and after that, face-to-face session to discuss about that.
Thanks, that's great. That's really, so e-learning reinforced with sort of face-to-face learning, that's fantastic. So Livia, coming to you, putting your operations hat on, I'm sure you're listening to this and thinking some of this is great, but what are the sort of barriers as well? Or what are these obstacles that you're thinking, could we do this here? Could we do this there? What's coming to your mind in terms of barriers? And then of course, I won't let you off because then I want to think, what are then a few solutions to those barriers? Oh, Livia, you've frozen. But she's frozen with a nice smile, which is always good. I shall then...
For us as
you're back. Livia, we lost you for a minute, so just give us the last sentence back.
Sorry, I was saying that first of all is the knowledge, because we have to do like the other hospital in the world. As MSF, we are a medical organization, and we have to be sure that all our medical staff is aware and is trained of this. So this, and I'm not so sure that we are doing. I'm less optimistic than Honorine. I'm not so sure that we are really 100% on the zero separation. This I'm quite, I have quite doubt. At least for what I see, I think at least in our mission we have to improve. I have to avoid. So it's maybe already put me in this panel, push me to study. So this can be one of the solutions, that I will push everybody to study and to force and be trained on this. I'm not able to see how many participants are on this section, but this can be one of the answer to your question, Kirill, to know how many PMR or medical referent or medical coordinator are participating to the pediatric day. not only on zero separation, of course, but this can be one of the solutions for MSF. So like we were saying, training, mentoring, e-learning, coaching is a culture that we have to continue and to build in MSF. And then, yes, the issue for me is that is as usual, we work as a silos, even in MSF. So it's if in the medical department we are speaking about zero separation, but then we have to speak, to involve everybody on Jesus, the ops, the log. I know that in the log construction book there is already the zero separation, but then when in practical we are going to design an hospital, we have to be ready that this is existing really, that is not only on paper, but in reality we still see little bed, no mother, no space for the mother or the family behind or together. So it's I think I'm not so sure. I think we have really to start from far, and for me the solution is really, first of all, like someone will say, work as a team. And remember that in MSF we are a team, and if you are not a team, we will not go anywhere. And then really the culture of learning. That is we cannot believe that what we learn when we start MSF is what we still have to do. We have to learn every day, every year, and I think voila, this is also a nice opportunity to learn. After, for sure, there are a lot of other steps, and definitely starting from the HQ. I have to say, it's has to start from there, and then going to the team in the field, and go away in the other way around, up and down, and right and left, and to see what are the challenges, because I'm sure definition of family and family approach is not the same everywhere in the world, and we have to adapt in the niche context in a different way. And for do this, we have to listen our team in the field and find our own solution that for sure will not be the same everywhere. But this is we have to be ready to this challenge. Voila.
Thank you, Livia. I think, yeah, that's, I think as medicine changes, and I think that's really important, isn't it? That we all have to stay up to date, and also to, you know, I think about back to my first mission and how I progressed and changed, and we all have to keep doing that in MSF. My next question is for you, Naomi, and we sort of thought about, well, we talked a little bit about sort of maybe some task shifting, and so it can kind of go both ways, isn't it? And that we don't want sort of, you know, some things that doctors or nurses traditionally did. Like, so what experience did you have in your hospital about task shifting, or not necessarily shifting, but sharing of tasks that can really facilitate zero separation?
So it was a bit of a task initially, because we had to train before starting the project. We had to train the nurses about the importance of zero separation. And initially, because we also didn't have CPAPs, they came a bit later. We also had to train them about the equipment, about the use of nasal prongs. So a lot of trainings had to go with the midwives, with the place of delivery, the labor rooms, in the theaters. And we had also to train the doctors that were also working in the unit. We had to inform them and tell them about the study, and we had to tell them about the importance of zero separation and importance of babies undergoing treatment while they're on their mother's skin to skin. So eventually, with time, people started understanding. Initially, it was difficult. People were scared, but later on they understood, and then they felt, okay, so this can be done. A baby who is sick can stay with the mother or the surrogate and still receive the same care that was needed initially. And if the baby was very sick, needing further care, yes, we would separate for that particular time, and later on she or he will return to the mother. So it was kind of a hard task, but later on we got the move of things.
Great, thank you, Naomi. I want to talk a bit about the continuum of care. So, Honorine, you mentioned this a bit, but talk to us a bit about and how your experience have been of trying to implement zero separation or even in KMC at a sort of community level in health facilities or beyond. Tell me a bit about the work you've been doing there.
I'm sorry, what we are doing now at community level? I'm sorry.
Sorry, that was for Honorine. Bárbara, I will hear from you later, but first Honorine, and then I'll come back to you, Bárbara.
Yeah, so now what we are doing?
Yes, in the community, you talked about it a bit just earlier on, but so just tell us a bit about how you really managed to get this, not just in hospitals, but as in health facilities or sort of in the community. You know, what's made that work and what has made it not work?
Yeah, so as I said, I was implementing zero separation in a hospital, but we were receiving many premature babies and the other babies, of course, who were coming from the community. So we don't have cars in a rural country, in a low income country like car. So we have outreach team, we have a health promotion team. We trained them as, of course, we are working as a team. And because the team of outreach, we have nurses, we have midwives, and now they trained the community, traditional birth attendants. So they are the ones who are still referring babies. Of course, we are facing many challenges. Many babies are dying on the way to the hospital, but at least when we started comparing where we are today, at least we are saving 50, like 70% are surviving. And we always evaluate at least every month, we evaluate where we are and where we want to be. Yeah.
Thank you, Honorine. I think it's a bit of a reminder, you know, that lots of these kids are dying on the way, but the fact that you are trying is fantastic. And then Tasmin, talk to me a bit about what are the differences in messages, or what are your different needs when you're in hospital versus having this kind of zero separation support at home if somebody's coming to you, or you're just going to sort of a more of an outpatient setting. What are your needs there, and what do you maybe see we need to do more of at that level?
Definitely, you know, prematurity is such a taboo subject still, unfortunately. So education is definitely key. Knowledge is power. If everybody on the ground understands the risks involved with a preterm child, you know, just general hygiene, simple things like that makes the journey at home so much easier. You know, when I think about when we were discharged, we went into complete isolation just because we were so afraid of bringing our premature baby into contact with people. And people were so very, very stubborn with regards to educating themselves, respecting our boundaries, our needs, simple tasks like washing hands and sanitizing, not coming around when you're sick, was such challenges for us back then. And I feel like the more we educate people, the better it will be, because I've seen the shift now. I mean, the COVID pandemic, as terrible as it was, actually opened a lot of minds to simple tasks like washing of hands and sanitizing and not coming around when you are ill, because of the detrimental effects it can have on a child that is born prematurely. So, I mean, at antenatal level already, would be nice to inform the parents, should you have a preterm child, this and this and this should be put into place and should be done once you're home, because like we're saying, like the mortality rate post-discharge is so high, and I honestly believe it's due to lack of education.
Wow, that's so interesting. And when you were saying about this sort of education, it kind of goes then beyond even sort of health facilities or even the family, because you realize it's your family and your friends who needed the education. And so if you kind of what would be the best tool that you want of educating those people around you to your needs and about the sort of the realities, the do's and don'ts of premature babies? What would be the most useful thing if you could kind of have it today in your hands? Is it an app? Is it a TV program, radio program? Like what do you think would be useful, or a little information thing?
I think it would differ from place to place, just because access is so different everywhere. Like it's easy to say, oh, an app, but like, you know, in Africa, getting data or even having smartphones is not very accessible for many people. So I feel like a lot of people definitely, they go to clinics. We have to go to clinics for checkups. So let's start there. Let's have a pamphlet, a brochure, people coming in to give talks. I mean, I was very, very impressed with my last pregnancy, that they did speak about premature birth, that they did educate about some signs and some symptoms, because we know that premature birth, you know, it's up and down. It's not one size fits all, but to at least know, okay, there are indicators, you know, if my blood pressure is too high or things like that. So if we can just let people know from ground level, like this is a thing, it's a real thing. Prematurity is affecting so many people. And we've seen an increase, you know, through this pandemic as well. So if we start just at the bottom and work our way up from there, we can go into fancy advertisements and stuff, but let's start with clinics handing out information. I like how Honorine was saying that they had outreach programs in the community. That would be great. You know, finding out about prematurity when you have a premature child is not the ideal situation. I would have loved to have had information prior, you know, like my premature birth was very unexpected, as is most. And then you thrust it into this world that you just absolutely know nothing about. And I mean, I'm 5 years into this premature journey, and I can tell you till today, I'm learning every day new things about prematurity. So if we can just provide tools and access and education. I mean, I know it's easy for us. We can go onto a phone, we can go onto Google, we can type in some, but not everybody has access to that. And we need to make it easier. And so that we can also educate the generations before us, because they are also very resistant, especially in the African context, like our grandmothers and great-grandmothers who end up being the primary caregivers in a lot of circumstances. They don't want to hear about these things. So we need to be able to educate them as well in a manner in which they would understand that, you know, if you do A, it's going to lead to B. We need to not do, you know, these type of things. So yeah, we just need to educate and start at the grassroots level.
Thank you. That's a really powerful message. I hope everybody's listening out there. Now, we're going to go now to some of the questions that are coming from our audience. Lots of great questions coming in. Thank you so much. Keep them coming. We will try to answer as many as we can. So one of the first ones that's come in that everybody's very interested in is IPC, of course. So infection prevention and control. Bárbara, let's start with you, and then I'll ask the same question to Honorine. But did you get pushback from IPC? You know, how did you address that issue? And sort of what were the things you did or the discussions you had that helped?
With family integrated care, we have demonstrated that we have less infection when the parents is the main caregivers of the babies. Obviously, the healthcare professionals, we are very worried about the infection, and many people think that it's worse if the family is included inside the neonatal intensive care unit, but it's not true. The truth is that there are less infection when the families are inside our units. Obviously, they have to learn about the hygiene, and they have to learn about what they have to put, to dress. But obviously, we can't forget that our patient is not only the baby, it's also the family. If you take account the family also is different, and in the infection is aware of the objectives in this type of model like family integrated care.
Thank you. That's really interesting. So infection rate is lower when families are involved. I think that's a really important message here. So the same question to you, Honorine. What discussions have you had with your IPC colleagues? What have been the sort of difficult discussions, and then the sort of agreements that you've come to be able to carry out zero separation, family centered care, and KMC in particular?
Yeah, thank you. So for us, we worked as a team. We included everyone because it was new. Even we had the support from ops, the PC, logistic, and what. So for us, yeah, what we did, we trained everyone first, the guards, medical staff, logistic team. And then it's not everyone who is like allowed to enter KMC ward. Yeah, so we have the guard who is controlled the movement, and we have also dedicated team for cleaners and hygienists who are trained in IPC. The same for medical staff. And then we even requested, the dress code for mothers. We have dress code for babies who are in KMC. And then we have, to clean the ward at least 3 times a day. So we have instruction for KMC. Of course, we had challenge because it was like starting from the scratch, It takes 3 months to convince people how to behave, that we don't have to enter the word KMC with our own shoes, because there was clothes dedicated for KMC. But now I would say that we are at least at 80%, and then we continue to reinforce sensitization. We are working with health promotion team. We have a health promoter dedicated for KMC ward who is sensitizing everyone. Yeah, wash your hands. Even it's not only for mothers or like visitors, even for medical staff, we have always to remind them. Yeah.
Thank you, Honorine. I think you're reinforcing as well what Livia said, the importance of being a team. Now, one question which has had lots and lots of likes, and it makes me hope that we've got some logistics people watching, but is how do we, so I'm going to ask this question, Naomi, to you first. How did you involve, the logistics or the facilities people in your hospital to help with creating a space that you really could do zero separation of KMC? How did you talk to your logistics colleagues?
Yes, so in our facility, there was a room that was given to us once we told them the importance of zero separation, and once we told them about the study, and once we educated everyone. So a room was allocated for us. In that room, we had 8 beds, and there were 8 CPAPs, and then we were able to recruit mothers, but then since it was a randomized control trial, we had to first consent, and then they were given a card. It all depended on what arm they were going to fall on, and then they were recruited consecutively. So we had a good support from the head of the hospital who gave us that room, and then it was renovated, and then the space fitted what we wanted to do for the study. And truly, we saw great reduction in mortality, and even hypothermia had improved, because we were taking these babies as the time they were born in theater, the time they were born in the labor rooms. We had already educated the surrogates, even though there were times they were not understanding. Being in Africa, they had so many notions, but later on they understood the importance of taking care of these babies right from when they were born. So we saw there was a reduction in hypothermia rates, and then there was a reduction in sepsis because we educated them again about the importance of IPC. And at the same time, the survival rate had also increased in the first 72 hours of all the babies, and even though at the end of the study, which was 28 days follow-up.
Thank you. That's really interesting. So maybe we can sell the idea to our logisticians by saving on heating bills, maybe. But just Livia, coming to you, put yourself in a position being a project medical referent or being, you know, a medical team leader of a project. Tell me the discussion you're going to have. You're going to knock on the door of the logistics office. How are you going to sell this? How are you going to get them involved?
Well, first of all, I think it depends when in the project we are, in the history of the project. If you are at the beginning, so in the construction moment, or if you have to make big changes. Because I think these are the important things to remember. At the beginning, I think it's in one side is easier, but it's a big, because usually we sit together and we speak and we make a plan and design, and it's easier to have a better flow of patient, a better organization. If you have to make a change, it's well, first of all, it's always again is a teamwork. An hospital meeting cannot be only the medical team, and this will never work. This we have to be clear. It's to be and medical doesn't have to be only doctor and nurse. It has to be HP, it has to be mental health, and everybody has to be convinced. But I think it's for me it's clear now that we were doing the same this discussion for an hospital in our project, and I think if the people doesn't see what we are speaking about, they will not follow. Once the log, in my experience, once the log understand what you want to do, then the things is done, and maybe you will find even better solution than what you were thinking as a medical team. So just really explain. A picture for me was already easy, or when I ask explication about what is really zero separation, I was trying to challenge and say, okay, even this child, yes, even this child. So for the log has to be the same, has to understand all the children, yes, almost all the children. So it's okay that you have you need a big bed and voila. But this is together. And don't be scared. Don't scare the people to have to make the stupid question. I think this is also the key of the explication. I was not afraid, or not too much, to ask the stupid question when I ask me the explication. So it's I think it's the same for everybody. It's allowed everybody to make the stupid question, and then we will be a team who understand.
Thank you, Livia. There's no such thing as a stupid question. And I think that's a really important element for our logistician colleagues, for our supply colleagues, is come with the problem. Don't always come with what you think the solution is going to be, because sometimes other people will be thinking in a different way, and maybe kind of out of our little medical bubble, they will come up with better solutions. So another question, which is really interesting one. So I'll ask this one first to Bárbara, but then I will come to you, Naomi, as well from the study, is that if this approach has had any effects on the rate and sort of nature of perinatal or postpartum mental health outcomes. So I don't know if, Bárbara, you managed to capture that information, or just even anecdotally from the people you've worked with. What's been your experience?
In my experience, the families who can care their babies, they are very, very happy. They have more confidence, and they are prepared to go home, because they have studied, they have trained, and they are prepared for that. And obviously, if you explain everything around the care of their baby, they are more relaxed. The depression and anxiety is lower, and that's important in this type of units, because it's very, very stressful to have a very sick baby or a very premature baby, and we have to try to avoid that psychological disorders. And if you can achieve only include the families, that's great. It's easy.
Thank you, that's great. And Naomi, I'm not sure if that was collected in the study or not. You have to forgive me for not having read that part, but did you collect anything on sort of quality, the experience of families, or even sort of any effects on postpartum depression or mental health status in your study?
No, it wasn't collected, but the few mothers, I mean, most of the mothers we spoke with at the end of the study, whenever they were being discharged, whenever we asked them, they were really happy. They enjoyed the fact that they could be with their babies. They saw everything that was happening to their babies. They understood the treatment that the baby was taking, and it was easy for them to explain even to their relatives of what was going on. And we saw that it gave them like a calming effect compared to the control group, because we would go and see, they would come in hours, like every 3 hours or sometimes every 6 hours to come and see their newborn. But these ones, and the control group would sometimes say, I wish I was also in the other arm where I could stay with my baby all the time. So really, we saw a great improvement and a great calmness. And I think because they could initiate breastfeeding early, they were able to do everything for their babies. Yeah.
Thank you, Naomi. That also speaks to this element I did see from your study that was actually stopped early because there were such important benefits. And it makes me think of you saying about this sort of the mums in the control arm, how difficult that must have been. Another question that we've had in is about the surrogates, which I think is very interesting. A few people have mentioned them, but I wanted to start first by putting this to Tasmin. How would you feel about somebody else doing this, about somebody else doing the KMC? I know it will depend on who it was, but you know, and how would you feel, Tasmin, about somebody else giving that care to your baby if you weren't able to?
Well, knowing what I know now, obviously with the information that I've received, absolutely I would allow somebody else to do it because the benefits are just so great. But obviously that would need to be explained. You wouldn't just want somebody, here's the baby, you know. But yeah, if the benefits were to be explained and you knew that was the best for your baby to survive and thrive 100%, I would definitely allow it.
Great, thank you. And Honorine, coming back to you with your kangaroo father care, tell us about how you've involved surrogates, including fathers, in this process, and what did you know, what was the best way to get them involved or get them to accept it, and obviously the mothers as well to accept it?
Yeah, so first of all, you have to know that the context where I was, you know, the mother is always coming with the father. Yeah, most of mothers, they are coming with the fathers. So when the mother is seriously sick, or maybe the mother has twins, yeah, so we started like explaining to the father the importance of kangaroo mother care. Yeah, the importance of zero separation. And then I would say like 90% they accepted without hesitating. And I said before, we even included the mental health team. They were talking to the father and to the mother, and because of culture barriers, when they will see the father, like, you know, carrying baby on the chest, what they will say, yeah. So, but the mental health team helped the team, the medical team, to handle that issue. And the fathers, I think, even if I'm not there, they are still practicing kangaroo father care. And we also like asked them the consent to take pictures, and we have like some pictures in the word, and sometimes we even show the new fathers, look here, you are not the first one who is doing this. And we are also, yeah, sure, we are doing the same for mothers. We have many pictures, we show the mothers, look, the previous ones, they did this and then baby survived. So can you do this also? Yeah. We are taking pictures before and after when they are coming back for follow-up. Yeah.
That's fantastic. That's a great idea. I really like that those pictures ideas. Now I'm gonna have one question, and then I'm gonna from the audience, and then one final thing I'm going to put to Tasmin. But this is a lovely question here, which, you know, gives us the spirit of debate in MSF, which we know is everybody loves. So this is this. Given the clear benefits of keeping mothers and babies together, we might wonder, why did we ever separate them in the first place? Should we even do neonatal care if we are not able to keep mothers and babies together? Now, of course, I'm just going to ask that hard question to Livia. She knows that was coming. So Livia, should we even be doing neonatal care if we cannot keep mothers and babies together?
I will answer with a question. Why we should not be able to keep together?
Ah, very good. You can see she's
I get it. I mean, it's a question of space, but we are in MSF, so we cannot attend. And I think then the fancy part will. It's for this that was what I was saying. That for me is quite sustainable as a part of the project. So the question can be what we are not able to add as additional care to the baby, oxygen or additional things. That this is okay, but this is always the question. But keep the baby with the mother or the father. It's a question of space only, and anyway, you will not kick out them of the hospital, I hope now, and then it means that are somewhere in our compound. So I think it's only here the mentality, and no, for me it's a question, and it's for this it is important that we change. But the reason is only why we don't have the space is because we didn't put it. Yeah. Only this.
Well, I like that. Why couldn't we keep them together? Now, just want to say a big thank you to all the panelists, but I do want to have one last thought from our mum, from Tasmin. Tasmin, if you literally had one sentence that you just wanted to leave this session and for MSF, what's the one short sentence, but the powerful message that you want to give to MSF and to everybody listening to this? No pressure.
Definitely that by keeping babies with their parents, they will survive and thrive.
That's enough for me. That's fantastic. Thank you so much, Tasmin. Thank you to all the panelists. We really appreciate your thoughtful answers, and we really think you've given so much food for thought. So I will close our panel discussion and hand back to Sophie. Thanks so much, everybody.
Thank you, Kirrily, and thank you all the panelists. I'm really speechless. I'm super happy to hear that Operation is saying there is no way we cannot do this. We need to find a way to do this. Thank you, Livia, for representing the operational aspect of MSF. So I have the big job of trying to summarize quickly the main messages of this session. So I think it was clearly during the panel discussion, during the presentation, that one, mothers and babies needs to be together right from birth. With a zero separation approach, we will revolutionize the care we provide to newborns, because it will allow us to implement a life-saving intervention such as immediate kangaroo mother care. We saw that there are many opportunities to implement zero separation along the continuum of care. Family-centered care leads to better health outcomes, improve experience of care, and empower families. We have seen it and we heard it from Tasmin Bota. However, we still have a long way to go in our fields. We need a cultural shift. We need trainings, but not only trainings, we need to change the way we perceive the problem. We need to involve all stakeholders to ensure a successful implementation of family-centered care and zero separation concept, using different strategies. Approaching the different challenges that will raise from a multidisciplinary perspective, not only from the health staff, but also from other profiles. We heard that logs, HR, admin, community engagement are important. And finally, we need to engage with mothers, with families and communities to really overcome the problems when they come. We have heard that there is fears and resistance from health staff on the risk of increased infection, which are unfounded, because we have heard that the latest evidence show that infections are reduced when mothers and babies are involved in the care. So finally, let's remember, mothers and families are not visitors. We need to open the gate, as Tasmin said in her presentation. They should be active actors and partners in care. Let's give the most vulnerable patients the best start in life. Please spread the word. And let's all start the change together. We need to start changing the way we see the problem. Thank you all. Thank you for the panelists, for the people behind the scenes who made this session possible, especially thanks to Ana de Lozada and Marge Hodges. the SRH working group, and everyone for listening. Thank you. Back to you, Myrto.